The topic for my second talk was intracranial catastrophes, which is a fairly broad topic to cover. So I've decided to focus that down a little bit. Again, nothing to disclose, no financial interests. Meet Uncle Frank. Uncle Frank has had a collapse at home. He's 72 years of age. And he's come in now and he's complaining of a headache. He's got some focal neurological deficit. His vital signs are pretty much as you see them there. So he's a bit hypertensive and a little bit tachycardic. In essence, he's presented with a stroke. CAT scan comes back. I'm not sure how well that's projecting, but it's not a thromboembolic stroke, it's a hemorrhage. A different kettle of fish altogether. And the major questions that arise in dealing with this sort of process, is there a time critical intervention that we need to bring into play here? Can we actually predict who's going to progress fairly rapidly and require more intensive or more rapid intervention? And are there any real strategies that we can bring into play that will improve outcome? We all know what we do in this circumstance. We all know the sequence that we will go through. It's interesting when you start preparing for some of these sessions and you start looking at some of the foundations for what we do, and you realise that there isn't a lot. It's an evidence-free zone. So I'm going to start with a little bit of the epidemiology. Hemorrhagic stroke accounts for a significant proportion of strokes, 10 to 15% in European type societies. In Asia, a significantly larger proportion, 20 to 30%. You're worse off with a hemorrhagic stroke than you are with a thromboembolic stroke in lots of ways, but particularly the natural prognosis. As it says there, the 30-day mortality is fairly high. Your capacity to be independent, living independently in 6 months is not very high. The 1 year mortality is extraordinarily high at 75%. The underpinning process most commonly has been understood as chronic hypertension, poorly controlled blood pressure causing small blood vessel damage. And the figure quoted for that for a long time has been 80 to 90%. But a recent review in Lancet, or systematic review, actually shows that more recent data is pointing towards the underpinning cause being hypertension, now only 50 to 65%. Why is that? What's changing? Well, first of all, generally we're getting much better blood pressure control in the community. We're seeing people living longer, so we see older people who are more likely to bleed. There's certainly an increasing utilisation of anticoagulants and a much broader spectrum of anticoagulants coming into play. And the final one, which is probably the least important, is that there are imaging techniques that are getting much more refined, and so we're actually picking up bleeds that we didn't see before. The nature of the problem is fairly straightforward. Most of the primary bleeds are small vessels, usually fairly deep in the parenchyma of the brain, and that accounting for about 3/4 or more of cases. The secondary accounting for the much smaller proportion, AVM malformations, hemorrhagic conversion of ischemic strokes, something we're seeing more often in the era of thrombolysis in stroke, and neoplasms. So what's happening? First of all, there's the bleed, and then the bleed begins to spread. It causes a degree of tissue change around it. That tissue change has been said to be ischemia, but there's some recent work suggesting that it's not so much ischemia as decreased oxygen utilisation in that perihematomal tissue. So it may be more salvageable than we first thought. And finally, the secondary injury, which is created by the traction and damage that spreading blood is creating, the physiological response in terms of an inflammatory response to the bleed itself, and finally the toxic effect of some of the factors being released from the hematoma, so thrombin, iron, hemoglobin, all causing tissue damage in their own right. Why am I telling you all this? Because it'll give you a bit of an underpinning for some of the potential therapies that are coming into play that I'll mention on the way through. So first question, can we predict progress? Can we actually look at a particular patient, their CAT scan, their clinical picture, and get an idea from that how quickly it is that they will deteriorate, or are they likely to deteriorate? There's a reasonable amount of work that's been done on this. One of the first things to look at is what's been the evidence of deterioration before they actually get to us in the emergency department. And there are a significant proportion of people who will deteriorate between pickup and being brought into hospital. And if they do deteriorate in that time frame, then they're at a much higher risk of a poor outcome. So no surprises, the sicker the patient, the faster the deterioration, the worse the outcome. That makes common sense, but it's nice to know that occasionally common sense is supported by the literature. And there's another incentive to say that if there is anything we can do acutely in terms of management, that we should get in there early, the earlier the better. Then are there predictors in the emergency department? Now, this is not hard and fast information in the sense that you can take this to the bank and use it as some sort of predicting tool, but what it does demonstrate is exactly the sort of things that are linked to progression. So you've got independent predictors, regular antiplatelet use, you've got the shorter time frame from being picked up to being brought into hospital, which adds up in the sense that, again, it's the sicker patient, the more urgent call they get brought in. If they come in and they have developed a fever early, if there is intraventricular hemorrhage or midline shift, all things which make reasonable sense. Those things in this particular study were all linked with a worsening outcome at 30 days in terms of mortality, and also at 1 week, and also poor neurological function at the end of the process. Like real estate, the other important thing is location, 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 and in a general sense, the deeper into the tissue that the bleed occurs, the closer to the brainstem that the bleed occurs, the worse the likely outcome. Obviously, because it's damaging more in the way of vital neurological function at that level. Hematoma volume at the beginning, so when you first do that CAT scan and you work out how big the bleed is, that is in fact said to be the strongest predictor of 30-day mortality, with 96% sensitivity and 98% specificity. And for each 10% increase in size of hematoma, so that's not one hematoma increasing 10% at a time, that's if you look at a series of hematomas as you go up in volume by 10%, you get a 5% increase in mortality. For the same increase in size, you see a 16% increase in the likelihood of a 1-point worsening in their modified Rankin scale. Now that last bit, I don't really know what that means because the modified Rankin scale is a bit subjective, but the take to the bank picture is the fact that mortality goes up significantly. Okay, the next thing is, not just how big is the bleed at the start, but how quickly is the bleed going to expand. And a significant proportion of hematomas will expand over time. No real surprises there because the brain is fairly soft tissue and the bleeding will continue. Roughly a third will increase in size by greater than a third, which is what you're really interested in. And it most commonly occurs early, 3/4 within the first 6 hours, and the rest usually within about 24 hours. And the risk of that expansion is related to that initial hematoma size that we're talking about as the primary determinant. There are other determinants. So you've got people who, again, it's the early presentation thing, and again, that makes sense. Sicker patients come in earlier. Use of warfarin in particular, so anticoagulation, and contrast extravasation on a CT angiogram, and we'll talk about that shortly in terms of what that might mean. When we look at anticoagulants as a component of this assessment, if you look at the figures that come from a lot of the major trials looking at things like warfarin and atrial fibrillation, they quote rates of hemorrhage in association with that of around about 1 to 3%. But if you look at some of the observational trials that have been done since, you see figures which go as high as 13% hemorrhage rates in people who are on warfarin. Now those sorts of figures get quoted in people who are ostensibly over the age of 80. But even if you look at younger patients, the figures appear to be higher than we've seen in the major trials, and that's a pattern that has occurred in research over and over and over again. So around about a 4% or so hemorrhage rate. We don't have any real-world setting studies to give us a real number as to exactly how that's likely to go. There are particular high-risk groups in those who are on oral anticoagulation in terms of hemorrhage. So the longer you are on anticoagulation, the more likely it is that you're going to have a bleed. If you are older, you're more likely to have a bleed. If you have significant hypertension, particularly poorly controlled hypertension, again, all this makes eminent sense. If you've had a previous ischemic stroke, you're more likely to have a bleed. That last term is something you can look at and then rapidly forget. It's basically non-specific deep white matter changes on a CT scan, something that the radiologists often report on, but I can't say I've ever gone over it. And if you've got an INR that's sitting at the higher level, greater than 3.5, but having said that, most bleeds still occur in people on oral anticoagulants at levels below the 3.5. If you, that's amazing, Microsoft and Apple don't marry after all. So if you use antiplatelet agents as well as warfarin, not surprisingly, you've got an increased risk of bleeding. Antiplatelet agents themselves, in isolation from oral anticoagulation, it's not absolutely clear how much of an impact they have in terms of what's available in the literature as to the risk of associated bleeding. There's some information, which is sort of sideline information from studies of a neuroprotective agent that suggests that they don't have any impact on the incidence of bleeds. But that particular one down the bottom there reported significantly worse 3-month outcomes in association with people who had decreased platelet function. And that's where they were actually measuring the platelet function as people came in, and primarily patients on something as simple as aspirin, never mind clopidogrel. There has been a systematic review that suggests that on balance the evidence would say that you are at an increased risk, and certainly my clinical experience, and I'm not sure about yours, but I'm sure it's fairly similar, is that if you're on antiplatelet agents, then you've got an increased risk of bleeding. People have begun to, as has been fairly commonplace over the last little while, put together scoring systems. And I'm not putting this up so you can memorise the scoring system, because I think there are 2 out there at the moment. This one, the FUNC score, and there's an intracranial hemorrhage score. They're not a useful thing in terms of I can get a mathematical number to drive what I'm doing, because most commonly that's not a useful thing to do. It doesn't have enough of an evidence base to run with. What it does do is it points out for you the important components of what you need to look out for in determining what this person's likely risk is going to be. So it points out those things we've just been talking about. What's the intracranial hemorrhage volume? What's the patient's age? What's their blood pressure like? Where has the bleed occurred? Piling those things all into the one basket. So this is, I mentioned earlier on, the CT angiogram, and this is the thing called the CT spot sign. So you do the CT scan, and it's got a formal definition, which is pretty much as you can read there. So it's spot-like and or serpiginous foci of enhancement within the margin of a parenchymal hematoma. It can't be connected to a vessel, so otherwise you might be thinking that could be a small aneurysm or something there. It has to be more than 1.5 millimetres in diameter. And it has to have a density which is greater than or equal to the background hematoma density. And the arrow you can see there is pointing to the little spot. I'm not sure how well that's projecting for you from where you're sitting. The importance of the spot sign is that if you're spot sign positive, suddenly you are picked out as someone who is at a higher risk of early expansion. And again, it sort of makes sense. If you've got dye that's extravasating, there's patently some active bleeding going on, which means then you are more likely to actually carry on and expand the damage that's already happening. They have, again, produced a scoring system. Again, not something that I would take to the bank at this point in time. But what it did do was point out that spot sign had an association with worsening mortality and worsening 3-month outcome. And guidelines now put down a class 2B recommendation to have a CT angiogram done when these people come in for precisely that reason. The original study that looked at this basically showed that if you were spot sign positive, and this was the primary outcome, that you were more likely to have a 6 mil or 33% growth increase in your intracerebral bleed. It also showed that your mortality, and the pink stuff at the top is the mortality relative to the blue stuff at the bottom, where you're spot sign negative, it suggested a higher mortality. The presence of, or prevalence of spot signs in the population of people who come in with intracerebral bleeds tends to lessen over time. So the longer it is before they get their head CT, the less likely it is you are to see a spot sign. But irrespective of that, if the spot sign is present, it maintains that level of risk for that particular patient. And there are several validating studies that show not only is it predictive of outcome in people who have a primary bleed, but it's also predictive of outcome in people who have a secondary bleed. So now we're at the phase of saying, okay, well, we can identify these things, we can put together a mix of things that we're going to look at to determine how well this person is going to do, how quickly they're likely to deteriorate. Can we actually do anything about it? This is a statement from one of the reviews of intracerebral hemorrhage, which basically says there are no proven in phase 3 trials of medical or surgical treatment for intracerebral hemorrhage that exists. Suggesting that no matter what we do, we haven't got proof that we're actually positively affecting the outcome. We all know that when we get someone like this, we usually make contact with a neurosurgeon and there's discussion about surgery. And it's widely accepted as life-saving in cerebellar hemorrhage in particular. But beyond that, we don't have a lot of information. What we do have is something similar to the stroke literature in terms of thromboembolic stroke, that if these people are admitted to a neurosurgical or neurological intensive care unit, they tend to do a lot better for all the reasons of the supportive care they get and the specialised supportive care in the process. So we stick to the basics to start with. It's the usual airway, breathing, circulation support, keeping them alive and trying to avoid secondary injury is our primary focus. Whenever you read about managing intracerebral hemorrhage, you read about head elevation, keeping the head up at 30 degrees. What proof do we have for that? Well, in terms of patient-orientated events, in terms of does it make a difference to whether this patient lives or dies or functions neurologically better at any point in time, we have no evidence. Literally zero evidence. What we have is disease-orientated information, which is that we can alter cerebral perfusion pressure by the position of the head. Whether that makes a difference to their outcome or not, we don't really have any supporting evidence. The other thing is obviously getting them off to that neurosurgical or neurology intensive care process as early as possible. In the meantime, we start to think about, can we stop the bleeding? So what can we do that might potentially get rid of that spot sign, not shrink the clot, but certainly stop the clot from getting any bigger and doing more structural damage to the brain? And the go-to treatment has always been FFP in the setting of people who, for example, are on oral anticoagulants or who've got some underlying coagulopathy. There's been a Cochrane review of FFP per se, looking at its efficacy. And the bottom line, and this is not just in the intracerebral bleed, this is looking at FFP to reverse bleeding in almost any circumstance. And the bottom line is that this is a treatment that hasn't actually been subjected to rigorous scrutiny to say that it actually makes a difference to outcome. What we do know is that if you can correct the INR to less than 1.4 within 2 hours, that's associated with a decreased hematoma expansion. Again, that's a disease-orientated endpoint, but it's giving us some signal that suggests that might be something that would be useful. If you give people FFP, the likelihood of an INR correction at 24 hours is linked to how early you give that FFP. But you have to be aware that 20% of people are still not going to be in that less than 1.4 INR level at 24 hours. Not surprising again, because the INR of FFP is about 1.5. So that theoretically is about as low as you are going to get it by giving them FFP. So the next thought that comes into play is we've got better stuff. There's newer stuff. There's Prothrombin complex concentrates, either the 3-factor or the 4-factor, depending on where you are and what you've got access to, that have become more prevalent and are now sort of part of guidelines for reversing warfarin when people have got bleeds. The CAMPRO registry, which has been following the application of this stuff for some time, shows that it works really well in terms of reversing the INR. In about 3/4, or just a little less than 3/4, you can have that INR reversed within an hour, which is what we're really talking about, getting less than 1.4 within that 2-hour time frame. What didn't happen, or hasn't happened, or appeared to happen so far, is that we're still getting significant hematoma expansion in almost 50%, and the in-hospital mortality rate is still climbing close to the same level. So we haven't really had a major impact in terms of mortality and outcome. The flip side of the coin is that having reversed the warfarin in the time frame for which they are in hospital, in the 30 days that people generally look at, they develop problems with the flip side of the coagulation process. So they get neuromas, they get thromboembolic strokes, they get DVTs, and that rate in 7 days is around about 2%. That may not be a reflection of a bad side of the prothrombin complex concentrates. That might just be that we've unmasked the underlying initial pathology we knew was there, which they were being treated with the warfarin for in the first place. But that's a question yet to be answered. There are people who have looked at other hemostatics, other things to stop the bleeding. There's been a Cochrane review of a whole series of them, including epsilon metoclopramate acid, activated factor 7. And the bottom line is that none of them appear to work. And activated factor 7 may well have a significant downside because of the increased incidence of thromboembolic events related to it. So that hasn't brought us into a positive outcome yet either. If you look at antiplatelet effect, or patients being on antiplatelet medications, there has been a systematic review that suggested, the one I mentioned earlier, that suggested that antiplatelet therapy is associated with an increased mortality. So if we could reverse that antiplatelet effect, could we get some sort of positive outcome? At the moment, transfusion with fresh platelets remains unclear. There's certainly no good evidence to say that it changes the outcome. There is a big study that's being recruited for at the moment, the PATCH study, which might give us an answer to that. But at the moment, platelet infusions, because someone is actually on an antiplatelet agent like clopidogrel or aspirin, is at this point in time with no proven benefit. It may help, but we don't really know that for certain. It's the sort of thing where you might have a discussion with a haematologist about whether that's the path they want to go down. I know that neurosurgeons that we refer to will very commonly want a platelet transfusion irrespective of the lack of evidence. But I think that's really just, it makes them feel better rather than making anything better for the patient. The other component that comes into this is these patients often present quite hypertensive as a component of the event and as a component of what their underlying problem is. And there's been argument to and fro about whether we should actually do anything about that blood pressure. It rises theoretically so that you can actually perfuse underperfused tissue. An argument easier to make in a thromboembolic stroke, but in someone who's actively bleeding. Have we got proof of harm? Well, we have an association. There's been a big Chinese study that showed that if you have a systolic blood pressure greater than 140 to 150 within 12 hours of your intracranial hemorrhage, that your mortality is higher. Well, we've got no idea whether that's cause or effect. Is it the high blood pressure that's killing them, or is it they've had such a bad bleed that it's pushing their blood pressure up and giving us that sort of a reading? There have been the Interact trials, which are international trials that have looked at using antihypertensives in this sort of a setting. They ran Interact 1, which is really a safety trial. Can they safely drop someone's blood pressure and not cause things to go badly? And then they ran Interact 2. And the bottom line from that series of studies is that there was no significant difference in outcome when you changed to the intensive blood pressure lowering regime. What you need, if you see this information, you need to be aware that this was not a study of no control of blood pressure versus control of blood pressure. This was control of blood pressure in an intensive fashion to get a systolic below 140 versus control of blood pressure to keep a systolic blood pressure less than 180, which is what's suggested in some of the guidelines. What we haven't seen is a study which compares no medication at all to control blood pressure and just let that run. So that remains the next question. The other complication of the intracerebral bleed that may be amenable to care is seizures. There's been a school of thought that we should give these people prophylactic anticonvulsants to avoid the downside of the seizures. The incidence of clinical seizures gets reported up to about almost 20%. The people who've had, within that first couple of weeks, the people who've had intracerebral hemorrhages. The incidence is much higher if you stick them on an EEG and watch what's happening with the brain rather than look at what's happening clinically. There have been 2 observational studies which have reported worse outcomes if you actually try and treat people prophylactically. So put them on phenytoin to avoid them having fits, and the outcome is worse than if you left them alone. What you do see in one large single centre study is that if you give them prophylactic anticonvulsants, it will reduce the number of seizures, but their outcome in terms of mortality is actually worse. Faced against that is the knowledge that when they looked at prospective and population-based studies of these patients, the fact they have fits doesn't seem to make their outcome any worse. So you have the intracerebral bleed, you have a seizure, your outcome on that data would suggest that it is going to be no different to the person who has the intracerebral bleed and doesn't have the fit, presuming that you control the seizure acutely. If you go trying to control the subclinical seizures, you get the same outcome. So prophylactically trying to control the seizures, you'll make the patient's long-term outcome in terms of mortality worse and disability. Okay, things are now going badly. The patient seems to be deteriorating in front of us. Is there anything else we can bring into play? Osmotic treatment is the thing that we move to fairly commonly, so you'll use mannitol or hypertonic saline. In terms of long-term outcome, they make no difference whatsoever. What positive evidence we do have for those relates to short-term gain to get them to some surgery to relieve the intracranial pressure. And in essence, there is no difference whether you use mannitol or hypertonic saline in terms of that outcome. Does surgery work? There are some well-recognised indications, or what people use as indications for operating in this circumstance. So particularly if you have superficial cortical bleeds within a centimetre of the surface, they're people that are deemed to be likely to have a good outcome from surgery. If they've got higher glioblastoma scales, if their volume is not too much or too little, then that might cause the neurosurgeons to actually operate in association with a superficial bleed. They also look at clot volumes per se in the general run of intracerebral bleeds. They'll look at people who are deteriorating and might use that as a trigger for surgery. Younger patients, obviously, for obvious reasons. If they've got someone who's got midline shift or elevated intracranial pressure, that will drive the neurosurgeons to operate unless they deem the patient unsalvageable. Cerebellar hematomas, particularly if they're greater than 3 centimetres and they're causing a hydrocephalus, causing a hydrocephalus, that would drive the neurosurgeons to operate. Putamental hematomas, as it describes there. Now, none of those are indications that have been formally tested in research. So what research has been done? There's the STITCH trial, which is a surgical trial in intracerebral hemorrhage, which found that there is no benefit to surgery over best medical practice. So they randomised over 1,000 patients. The premise was that the clinician had to feel that it was unclear as to whether surgery or medical treatment was going to be any better for this particular patient. And they got surgery or just best medical treatment, and the outcomes were identical on the 6-month mortality and the Glasgow outcome scale. There's now a study underway, which is, I think, STITCH 2, which is looking specifically at the subgroup with the shallow subcortical hemorrhages, because that subgroup in that particular study had a trend toward benefit. So they're actually doing a separate trial to see whether that subgroup can have some proven benefit if they look at a bigger number. Cerebellar hemorrhages, there have been several non-randomised studies. the beneficial outcomes compared to medical treatment seem to be if you've got that diameter of exceeding 3 centimetres, or if you've got compression of the brainstem, or a hydrocephalus that's being developed. So where can we go from there? They're all the standard things that everybody would know about and have seen and have applied. And there is still a sense of inevitability or fatalism when it comes to intracerebral bleeds about the outcome not being such a good thing. So there are multiple avenues that are now being tested in research. This is one of them, where they actually go in stereotactically, they suck out the clot, they put in some plasminogen activator to actually break down the clot. The all sounds a bit dodgy if this is the point of bleeding, you put in the plasminogen activator, but the concept being if you can liquefy it and get it out, you're removing that pressure effect and the traction effect. You're removing the clot which contains those toxins I talked about before, and potentially improving the outcome. So that's the underlying theory. The SICHPAR trial showed no significant effect on a 6-month functional outcome or mortality. They did get the volume reduction they were after within 72 hours of onset. There are 2 other trials which show that it's safe and some early improvement in their functional capacity, but they're both small trials again, so it's early days with that stuff. But that is a potential therapy that may come into play. There are also new medical therapies. The desferrioxamine seems like an odd thing to be throwing into the mix, but that's premised on the concept of iron-free radicals being within the tissue from the clot, and if they can use the desferrioxamine. Now that's been a proven benefit in rats. So that's the phase we're at with that stuff, but it is something which is moving through the investigative process at the moment and may come up in the next couple of years. There are a number of medications that are being used for anti-inflammatory effect. Again, very much at the early phase of trials, animal trials, that sort of thing, to see whether they're going to be of any benefit in avoiding the inflammatory damage. So, back to Frank. What could we do for him? Well, I've just pointed out that there's not a lot of evidence that a lot we do is going to make much difference at all. So the standard is still going to be, we're going to do our best to maintain normal and functional airway breathing and circulation. If he's on oral anticoagulation, then we would consider the possibility of reversing that oral anticoagulation using prothrombin complex concentrate plus or minus some FFP. The downside of FFP in this mix that I didn't mention before is that if you give prothrombin complex concentrate, it's not a big volume. If you give FFP, sometimes it can be a big volume, which can be an additional issue for some patients. Certainly standard therapy at the moment is we would attempt to reverse that, even though the evidence we have is that we haven't got any proof that it's going to change the outcome. We can change the number, we just don't necessarily change the outcome. If there's an antiplatelet agent in play, there's no proven role for platelet transfusion. My advice would be to leave the blood pressure alone, but if you are tempted to do something about it, be extremely careful what you use and how you use it so that you titrate it down and you don't drop it too precipitously. Don't give prophylactic anticonvulsants. So you can give anticonvulsants if they have a fit for obvious reasons, but don't give them to avoid the seizures. Mannitol if you have to get them to theatres, and an early discussion with the neurosurgeons for the subgroups who might potentially benefit from the interventions of surgery. Any questions?
Were you aware of anyone who's using the new wonder drug for traumatic hemorrhage or hemorrhage of traumatic origin is TXA, tranexamic acid? You know, it's cheap, it has no side effects, the thrombotic effects you've seen with Intracranial. Are you aware of any neurosurgical applications for that?
Only a couple of small studies that effectively haven't shown a great deal of difference in outcome, and not enough to be able to make it. It fits into that same group of the Cochrane stuff that looked at a number of hemostatics that seem to make no difference in outcome. So at this stage, it might be something that proves to be beneficial over time, but there's no evidence for it yet.
I just have a quick question. With respect to intracranial hemorrhage, any difference in blood pressure management recommendations for subarachnoid versus your typical intracranial hemorrhage?
Okay, so, I mean, subarachnoids are sort of a separate story in the sense that there is some evidence to suggest that things like monopene might make a difference with subarachnoid hemorrhage and the outcome of subarachnoid hemorrhage. That's about the only difference that I can see in that process in terms of recommendations. The guideline recommendations for intracerebral bleeding effectively sit on a foundation of sand because there's no data to support them. And they will look at the presence or absence of do you have a systolic above 200, do you have a systolic above 180, do you have an association with that, the particular type of clinical pattern they presented with as to whether you should, so is it a subarachnoid or is it an intracerebral bleed? And they make recommendations that you can use, but they're not hard and fast. They're very careful about saying that if you're going to do it, that this is the way to do it, and these are targets you can go for, but we don't really have any evidence for why those targets exist or why they are set at the levels that they are set. It seems to have been an arbitrary number that's been plucked out of the air.
Okay, we're going to get ready. Before we take a break for lunch, please thank Andrew again for his... Lunch is served. I don't know if folks are staying here that know where breakfast is served. Lunch is served in the same area. Again, it's complimentary to all folks who are registered. I would also like to just mention that there are 2 tracks this afternoon. There's a simulation track that's going to be led by Claire Richmond and Anthony Lewis, and that's going to be conducted in the smaller room. It's a hands-on interactive session, so for folks who are interested in simulation, I think it's an excellent opportunity. We're also having a second track that's in here, and that's dealing with IT in emergency medicine. We're going to have Joe Lex speak on phone. Peter Vicelio is going to speak on using the iPhone as a diagnostic tool, and we're also going to have John McKenzie speaking on IT as it relates to emergency medicine and education. We're also going to have we'll bring in one of the computer workstations in here that are going to be donated around the region. If anyone's interested, John can talk about. He's had the most input in this, and basically John's the one who's created the online curriculum that's also going to be placed on these workstations. That has been placed on these workstations. So it's an opportunity to have a look at those. They'll be around all week, so you don't have to do it necessarily today. So have a break for lunch, and we're back at 2:15, either in this room or the room that's basically across the hall.